Shall I start? Okay. Hi all, and hi all, and welcome to this another session on the embryology. I'm Dr. Ankit, your faculty of anatomy in Auricle platform, and this is the 21-day revision series live class for university exams. Today we are into the second session of the embryology. Yesterday we did the first session, in which we basically dealt around the general anatomy. We just continue from there, and then we'll also look at some of the development, very important, of the CVS, that is basically the heart development. So let's start. These are some of the questions or some of the topics that are important. Even you can take the screenshot. So here they're asking about the organogenesis of the cardiovascular or nervous system that we are going to cover, about the heart development, muscle development, placenta we discussed yesterday only, three germ layers and what organs do they give rise to. If you remember, then in the end of the yesterday session, I gave you some homework, guys, so that you can go through these derivatives as well, though we'll touch on it as well as today, about the folding and about the teratogens. So yeah. So these are some of the topics that we are going to touch in today's session. Why to choose Auricle? Here are all the features of Auricle, from recording, live classes, practical sessions, hard copy, notes, practical, exam module, and all this. You can see all the features of foundation classes, live classes, exam module, doubt clearing, hard copy notes, Q banks, practical sessions. So literally everything is more or less covered over here. Last slide over here regarding this Auricle. Here we are seeing all the subscription plans, and here is the price bracket given for depending on the duration. So from 3 months to 6 months to 12 months to around 4 years, that is more or less a complete MBBS plan is also available over here. And the price bracket is given below, and you can also use the code that is on the bottom side, Dr. Ankit 20. You can use the code Dr. Ankit 20 to have some attractive discounts on the subscription plans. Okay, let's move on to the topic now. And as we have seen, the topic over here is the embryology part 2. Let us see about this embryology part 2. Okay, so let's begin over here. So if you guys remember, then these were some of the slides that we talked about yesterday. I'll just go through it quickly, and then we can proceed from where we left the previous session. So this image, if you guys remember, then we were discussing yesterday about the weekly development. So there was week 1, week 2, and week 3. Week 1, we had studied from fertilization to beginning of implantation. Week 2, we saw how the implantation proceed, and everything, nearly most of the thing, they divided into two structures, as you have seen. Week 3, we saw about the main two events that occurred, that was the gastrulation and also about the neurulation. In fact, we also saw an electron microscopical image to show you about the various parts or subdivisions of mesoderm, right? That also we'll try to touch today. So this image, if you remember, that was 16th day. So you can see this primitive streak over here, helping in which process? It helps in gastrulation, because this is week 3, right? And week 18, oh, sorry, day 18, so that gastrulation process is continuing forward. Here you're seeing the day 19. So now the neurulation also has started to begin up. You can see in this neural plate, also known as neuroectoderm. This I'm just revising from where we ended the previous session. This is a neural plate, so neurulation has also begun, right? And the neural folds are coming over here. You can see the neural folds. The days are given below, right? It is day 19 was this one. This is after 1 day. And then on the 22nd, 23rd day, that is third week is over. Now we're entering into the fourth week. Apart from the neural folds, what else you see are these small boxes over here, right? These are known as what? These are known as somites. They are a part of mesoderm, particularly paraxial mesoderm. Which mesoderm? Paraxial mesoderm. Okay, that also we try to touch. I will just show you that image again so that we can see. Yeah, this was the image. So as I told yesterday also, this is a transverse section of the developing embryo. And what you're seeing at the top, this was the ECT ectoderm. Below we had a layer of END, that is endoderm. In between you have seen the neural tube. And if I ask you what will be just below the neural tube, it was the notochord, right? Do remember that this notochord, its ultimate objective was to initiate or to transform some ectodermal cells or to specialize some of the ectodermal cells to become the neuroectoderm, right? But apart from this, if someone asks you, and that has been a question also, that okay, sir, neural tube will become CNS. So this will become our brain, this will become the spinal cord. That is good. What about the notochord? Does it disintegrate, or is there any remnant of it that is present in an adult also? Yes, there is a remnant, and the remnant of notochord is what we call it as nucleus pulposus. Now, some of you who might have heard about it, very good. For those who haven't heard about it, it's a part of the intervertebral disc, that disc between the two vertebrae, the body of the two vertebrae. We have a disc, no, it's a part of it. Okay. Apart from nucleus pulposus, it can also form tectorial membrane. This you will study when you will study the head and neck, right? So there is a craniovertebral joints, the joint by which the head is fixed or is placed over the entire trunk. You have a joints over there. In that, you will study about the tectorial membrane. So yeah, these are some of the remnants of notochord. So don't forget this too. That can be asked as a separate question or as an MCQ. Fine. Now coming to the mesoderm. The three types of mesoderm that we discussed. First is this somite part. So let me change the color a bit so that we know that what we're dealing with. This is the first, just lateral to the main axis. Main axis is what? Main axis is where the notochord and the neural tube is placed. Just lateral to it, the first part is somite, that small boxes which I just showed you. It is also known as paraxial mesoderm. Paraxial mesoderm. Just lateral to it, a very small part over here, and also on this side, we can see this is second part. And as it is, there are three parts of mesoderm. As this one is the middle width, so we call it as intermediate mesoderm. And the one that is present most laterally, most outside, is the lateral plate mesoderm, right? Lateral plate mesoderm. So now we should have a good idea what do they actually give rise to. But look at the three mesoderms. Look at the somite over here, look at the intermediate, and look at the lateral plate. In the lateral plate mesoderm, you will see that there is some sort of cavity inside. Yes or no? There's some sort of cavity inside. So it is like a it forms like a tube, not exactly a tube, but like a tube. It has two layers. This one layer over here, which is facing which side? It is facing the ectoderm. So this part of the lateral plate mesoderm, which is facing the ectoderm, will be the somatic layer of lateral plate mesoderm. Must have been labeled somewhere. Yeah, parietal layer or somatic layer. Right. This one is the parietal or somatic layer. While as you see that the lower layer, this layer was which one? This was the endoderm. So this part of the lateral plate, which is in contact with the endoderm, that will be the visceral layer of lateral plate mesoderm. So there are two layers, one in touch with the ectoderm, this one in touch with the endoderm, this one. One is known as the parietal, or you can also call it as the, as I said, the somatic layer. The one in touch with endoderm is known as the visceral layer. And between them, you have a cavity that is coelomic cavity. That is cavity known as coelomic cavity. Now, you might wonder that's why are you explaining sir this much in detail. The reason over here is that if I tell you that what does this coelomic cavity is actually in adult life, then you'll understand the importance. This coelomic cavity in adult life, it becomes the pericardial cavity. The pericardial cavity. It becomes the peritoneal cavity. It becomes the peritoneal cavity. It becomes a pleural cavity. Right. So now you understand that when we talk of pleura, pericardium, or peritoneum, we always say parietal layer, visceral layer, parietal layer, visceral layer. So those parietal layer of peritoneum, so all the parietal layer of peritoneum, parietal layer of pericardium, parietal layer of pleura are coming from this parietal layer. And similarly, all the visceral layer of the pleura, peritoneum, they will come from here. And in between them, you have a small cavity that is a coelomic cavity. Now I got the point why there are two divisions. Well, that sort of division is not present in somite and your intermediate mesoderm. Now the question comes that, so okay, then sir, what do they actually give rise to? Somite and intermediate mesoderm, what do they actually give rise to? Okay, that we'll see. So very easily see intermediate mesoderm over here. Just one word I will answer about the derivative. It gives rise mainly to the genitourinary structures. Genitourinary structures. Genitourinary. Genito means related to genital system, and urinary related to the urinary system. Not all, but yeah. Most of the structures in genitourinary, they come from the intermediate mesoderm. Likewise, testes, ovary, then related to testes, we have those ducts and all. kidney, they're coming from the intermediate mesoderm. Now, what about the somite over here? This somite or the paraxial mesoderm is actually quite diverse and it divides into various other things. Let me find an empty slide over here and try to answer over here. So let me make a small sort of table. And if the question comes about the derivatives of mesoderm, guys, in your exam, better to make a flow chart. Mesoderm divide like, yeah, somite over here, okay, or paraxial mesoderm. Then talk about the intermediate mesoderm and talk about the lateral plate mesoderm. Divide this lateral plate into again parietal layer and visceral layer and give name the derivatives and all. Similarly, intermediate give the derivatives. Now the somite over here, this is the paraxial mesoderm. This is what? This is the paraxial. Why paraxial? It is just parallel to the main axis of the embryo. This actually, somites actually can make even a flow chart. It divides into few of the structures like sclerotome. What is that? Sclerotome. Then dermatome. Then dermatome. Then myotome. Okay, now having a common sense or common nomenclature knowledge, we know when we talk of sclerotome, we are actually referring to the skeletal system, right? Sclerotome is skeletal. So it will, over here, sclerotome will form some bones. Now think about an embryo, an adult body, forget the embryo, there's a human being. And it is very close to the axis. So very close to the axis, which bones are there? Common sense. You have the vertebral column. Yes, it gives rise to the vertebral column. And related to vertebral column in thoracic part, we also have the ribs. We also have the ribs, but no, sternum is not present over here. Sternum is derived from some other source that we'll see, right? So vertebral column, ribs, even some part of the skull comes from the sclerotome only. Now dermatome. Dermatome means what? Dermatome means dermis. Now if I give you two options over here, will it form the dermis of the anterior or the ventral body, or will it form dermis of the posterior or the dorsal part of the body? What will you answer? Sir, I don't know, sir. Think about it. Think about it. This whole sclerotum, this whole somite was present where? In the posterior part. Let me show you from this image. Look at the images. This is the developing embryo in 25th and 28th day. Till 28th day, you are seeing the neuropores also being closed. Now, these are all the somites. Where are they present? In the anterior part or the posterior part? They are present in the posterior part of the developing embryo. So the dermatome over here will form the dermatome of the posterior or the dorsal body wall, not of the ventral body wall. Understand this part. Then comes the muscles. Muscles. Myotome. Myo means muscles. Myology. Myo means muscles over here. It forms the muscles of the entire trunk. Trunk means our thorax abdomen. It will form the main muscles of entire limbs, upper and lower limbs as well. Just imagine what I'm writing over here on my electronic pad over here. By moving my hand, the muscles are derived from this myotome of the paraxial mesoderm. Okay, paraxial mesoderm. Okay, so it gives rise to the skeleton in a nutshell. If I want to summarize it, because people might get confused now, sir, how much to learn, sir, how will we learn? See, it is try to simplify it. There's too much of knowledge. There's too much of stuff, too much of data. You have to somehow in your head simplify so that you can retain the knowledge. While giving answers in your text or in your theory exams, then you have to elaborate it. Okay, but for your own understanding, you have to simplify the stuff. If you keep it very wide open, if you try to indulge all the stuff, then things become very complicated. So how to remember the somites? Somites simply, they give rise to, in a nutshell, axial skeleton. Okay, not the appendicular, axial skeleton and muscles. Most of the your somatic wall muscles are coming from the somites. Then what is left over here? So what about appendicular skeleton? Our humerus, radius, ulna, all these bones we've studied in upper limb. What about the appendicular skeleton? Which mesoderm? Because this skeleton is bone and bone is mesoderm. So appendicular skeleton is derived from where? Think about it. Is it if it is not the somite, is it intermediate? But sir, you said intermediate only give rise to your genitourinary structures. Okay, then what is left is the lateral plate. Now see lateral plate, think about it. It is present outside laterally. So the cells from the lateral plate mesoderm, they can easily migrate outside. Now, if you look at the body also, we have the trunk over here. Imagine the trunk, the neck, and the head over here, okay, and the head over here. The upper limbs and the lower limbs, they are coming from the outside, they are appendages. So this appendicular skeleton comes from the lateral plate mesoderm. Think about it. Comes from the lateral plate mesoderm. So when the lateral plate mesoderm gives rise to the bones, then these myotomes, they are also present on the lateral side of the somite. They are actually being pulled by the lateral plate mesoderm and they give rise to the muscles, while the bones are coming from the lateral plate. So muscles coming from the somite of the appendicular skeleton, and the bone itself, they come from the lateral plate mesoderm. So lateral plate mesoderm not only forms this parietal and visceral layer, not only pleura, peritoneum, and your pericardium, but also the appendicular skeleton, even your linings of the heart also coming from here. So remember this basic mesodermal differentiation. Okay, what else are we there for? Is left to for us to remember to be derived from is the ectoderm and the endoderm. So for that, I'll show you a couple of tables so that you can understand this. But apart from all this knowledge, we have how many germ layers? We have three germ layers, right? What three germ layers? The ectoderm, mesoderm, and endoderm. Okay, just a second. Let me erase this a bit so that we have some space. But there is, what if I say there is one more germ layer? Apart from these three, there is one more germ layer which is said to be the fourth germ layer. Now, which would that be? There is also one more germ layer apart from ecto, meso, and endoderm. There is one more germ layer that is known as fourth. It is regarded as fourth germ layer. Basically, it is not the fourth germ layer, but actually, its cells are basically coming from the ectoderm. When the neuroectoderm separates itself from the surface ectoderm, because there is a tube, no, there's a neural tube being developed. The tube will be developed only when the neuroectoderm separates itself from the surface ectoderm. Now, when that separation happens, there are few cells which are present on the edges of the neuroectoderm, somewhat over here, if I may, somewhat in this location. There are some cells which migrate or which detach itself from the ectoderm, and they don't fuse with the ectoderm, nor do they fuse with the neuroectoderm, nor do they fuse with the mesoderm, nor do they fuse with the endoderm. They are known as neural crest cells. So these neural crest cells, crest means on the edges, neural crest cells, these neural crest cells, why are they regarded as the fourth germ layer? I'm not saying they are said to be. The reason behind it is that they are very much migratory and they migrate to a lot of places. They'll form the ganglia somewhere, they form the adrenal medulla somewhere, they form the melanocyte somewhere, they form some of the meninges somewhere. So they migrate a lot. They are therefore regarded as the fourth germ layer neural crest cells. Where are they present? On the edges of the developing neural tube, and then they migrate. That is a fourth germ layer, right? So now this whole knowledge over here, let us see what are the various derivatives. Now here is a chart or a table showing you the neural crest derivatives, just what we were discussing as the fourth germ layer. And this is very, very important for your vivas, for your theory, for your MCQs. You name the exam. Okay, in embryology, if there are 5 questions, supposedly from embryology, there are very good chances one of them would be from the neural crest derivatives. So as you can see what are they actually forming. If you go from point 1, just read through it. See, there's no need to cram it. People will make a lot of mnemonics for it, fine, but just read it for a few times. Make a printout of it, or you write down, you learn it, write down on a sheet of paper and then place it in front of your table. You read it again and again and again and again, so that you are not dependent on the mnemonics. Mnemonics do help. I am not anti-mnemonic over here. They do help, but you have to use them judiciously. Else your textbook is this much and half of the textbook will be based on mnemonic only. Your 90% of the time will be based on learning mnemonics only. And then you have to learn that what is this mnemonic for? Then you have to fill that mnemonic. So it becomes actually a big exercise than learning the stuff. Okay, this learning the stuff is a direct stuff. You're directly seeing the stuff, learning it, and then making mnemonic. It's an indirect, and sometimes going through the mnemonic becomes a little bit more complicated and direct. So I will tell you where to use the mnemonics, but it is not used everywhere. Learn that. So understand neural crest derivatives. Now, before going to again this, let me tell you one more thing over here, which might initiate some interest. Why? mean, practical knowledge of this. There's a newborn child you are seeing in the gynae or the pediatrics ward, and there's some congenital anomaly which you see in that particular child. Suppose there's some congenital heart defect. There's some CHD, also known as congenital heart defect. Okay, the child turns blue, and you go for the ECG or echo, and you detect some anomalies, right? So now okay, you're very happy. Okay, I have found out some heart defect, so let's repair it, and good. But if you know that this congenital heart defect or this defect is the defect of the neural crest cell, because the neural crest cells, if I show you over here, yeah, oh, this fourth point, the conotruncal septum of the heart. So this neural crest, they give rise to the conotruncal septum. But if you are seeing in a newborn child a defect in this particular conotruncal septum, you know by your knowledge that there is some defect in the neural crest cell migration. So should I check other stuff also in this particular child? I might find something. I get your point. And this actually happens. For example, there's parasympathetic ganglia over here. Okay. This diseases, which is quite common. If all the diseases, we have a disease in a newborn child known as Hirschsprung disease. Hirschsprung disease, or also known as congenital megacolon. It's a disease of the gut. Okay. The stools are not easily passed, and there's a colon that becomes big in size. And a distal part of the colon is very narrowed down. So there may be problem in the parents might, or the mother might complain that the child is not passing the stools. His stomach is looking like is swelling up or bloating. He's always crying. There's pain and all. Getting a point. So a simple diagnosis of this, then you can also check about the heart. So connective tissue, the bones of face and skull, that you can easily see. Okay. Then you have cranial nerve ganglia. Understand cranial nerve ganglia also. So there can be problem which you not might easily elicit in a newborn child, but yes, you have to keep that in mind. See, as a thyroid gland. Understand? Odontoblast in the teeth, dermis in face and neck, spinal dorsal root ganglia. Again, all those. There's a sensory pathway of the spinal whole nerve pathway that can be damaged. Adrenal medulla, understand this. There can be tumors regarding this. Schwann cells, again of the nervous system. Glial cells, meninges in the brain, melanocytes, skin color. So see, if you just go through it, okay, and you know, okay, at least this, I know this 5, 6 main structures that are derived from the neural crest. This might help you not just in remembering, but also later on in your whenever you see some cases. Let me actually highlight the important one at least. And these are the must know: odontoblast, spinal ganglia, parasympathetic ganglia, adrenal medulla, melanocytes. These are the must know. Though if you read again and again, then when slowly you will get to know this. These are neural crest derivatives. Let us see one more table. Derivative of the ectoderm. Let us see surface ectoderm. Remember surface ectoderm? So it basically gives rise to skin, hair, and nails, and not the entire skin, only the epidermis part of the skin. So skin, hair, and nails. Then look here, surprisingly, inner ear and external ear. But so there are 3 parts of ear. There is also middle ear, yes, but middle ear does not come from ectoderm. Middle ear will come from the endoderm over here. If I may try to show you, here it is, the middle ear. Getting a point? Remember this tricky points. Then eye lens of the eye. Then anterior pituitary part, parotid gland. These are enamel of teeth also, right? So remember these few things which come from the ectoderm. Very important derivative. Over here, I will highlight you for you guys about that ear part, because that might be confusing. Inner ear, external ear from here, and the middle ear and the auditory tube is coming from here. Then look at the mesoderm, the one that is actually very diverse. Okay, very diverse. You can say it has more, numerous number of portfolios are there in the mesoderm. So it muscles that form nearly all the type of muscles except few muscle. I will give you a question also. Connective tissue, all serous membrane, bones, cartilage, blood, lymph, cardiovascular, adrenal cortex. Now see adrenal cortex over here and look at the adrenal medulla over here. So the question comes, adrenal gland is derived from, you will say it is coming from neural crest also, and it is also coming from the mesoderm. Cortex comes from mesoderm, medulla comes from neural crest. See? So gonads, intermediate mesoderm, kidney, intermediate mesoderm, spleen, you have the mesoderm, dura mater. So this is all about the mesoderm part. Okay, right. And here we have the endoderm. Endoderm is the inner lining. Understand one more thing before we proceed further on, because we have seen confusions over here. See, imagine this is the endoderm, red color. Okay. Just bear with me for 1 minute. I will let you know concept. This is, imagine the black color ectoderm, and let us say one more, say green color, just for the sake of me over here like this. This is the mesoderm. Now, clear? Colors clear? Black is ecto, green is endo, and red is your endoderm. But the body is not shaped like this. In the body, if you see, the entire skin, hair, and nails are present outside. So what actually happens is there is folding of these structures. There is folding of this trilaminar disc. There are three germ layers, no? So we have trilaminar disc in week 4, and in week 3, and in week 4 the folding, the embryonic folding starts. When the folding, what will happen? Try to understand over here. This folding, the inner layer is the endoderm, concentric layer. Outside this endoderm, then we have the outer, that is the mesoderm. Are you with me? And then the outermost over here, this is going to be the ectoderm. This is how just to give you an idea, how the actually body starts to shape itself. So if you see over here, entire skin, hair, and nails, they are present on the outside, ectoderm. In between bones, cartilage, muscles, and all, they are mesoderm over here. And in the center, we have the endoderm. Now look at the endodermal derivatives. GI tract, foregut, midgut, hindgut, at the center or in the middle of our body. The respiratory tract, the genitourinary system. Now you say, sir, but sir, you said the genitourinary from intermediate mesoderm. I didn't said all, but yeah, part of it. Part of it comes from the endoderm also, like bladder, urethra, lower vagina. The kidneys and all, kidneys, ureter, they were coming from mesoderm. Okay, then pharyngeal pouches that you'll learn in head and neck. Okay, what endoderm comes from here? You have the parathyroid gland, the thymus, that you learn more in the topic of, or the embryology of head and neck. The pharyngeal arches is one of the most important topics of embryology. Okay, so these are pharyngeal pouches. So they are coming from the endodermal derivatives. One more slide over here. Yeah, again, neural cast, we have done that as a repetition. Notochord also I told you. Neuroectoderm again. So it is forming the CNS. So it is having your brain and spinal cord. Now from the brain and spinal cord, some out pouches will come. Okay, and they will form your retina and optic nerve in the eyes. Eyes are actually brain. Eyes are actually brain. The part of the brain that you can see are the eyes. And remember this part. Pineal gland, neurohypophysis. What is neurohypophysis? It is the posterior pituitary gland. What does it give rise to? Vasopressin, oxytocin. If you remember a bit of physiology also over here, posterior pituitary. Then astrocytes, oligodendrocytes. What are these? These are the neuroglial cells. They are the CNS supporting cells. They are also coming from the neuroectoderm only. And this is endoderm continued. On the previous page, liver, pancreas, a couple of. So remember these 2, 3, or basically these two tables over here. Go through them again and again and again, and your life will be very easy regarding the embryology side, right? Okay. Now let us see some of the MCQs, and then we'll come back to the developing heart. Now, just give me a second. Right over here. Okay. Let us do some of the MCQs over here. Okay. Here's a question. Here's a question that iris muscles are derived from. And we have few of the options over here. Option say surface ectoderm, neuroectoderm, mesoderm, and endoderm. Now looking at the question, okay, sir, muscles. Muscles, yes, sir, muscles. You said, sir, it is mesoderm. Mesoderm, okay, option C. This is one of the exception. Iris muscles present inside the eye. They are intraocular muscles. Right, and remember intraocular retina optic nerve, they are coming from the outpouchings of the neuroectoderm, the neural tube. The iris muscles are one of the rare muscles which are coming from the neuroectoderm. Answer over is the option. Remember this. This is frequently asked question in your theory, MCQs, vivas, you name it. Okay, let us see one more. The question over here goes like, just a second, the notochord forms the initial axial skeletal element of the body and induces the formation of neural plate. Agreed? Which of the following structures is the soul? Soul means only. Postnatal, that is after birth, remnant of the notochord. I guess we all must be knowing. Search for nucleus pulposus. If you find it, very good. If not, then search for tectorial membrane or membrana tectoria. Okay, let us see one more. Disruption of the further development of the structures. It's an image-based question indicated by the X, right? Could directly affect the formation of which of the following structures. So what are these X over here? Well, we have seen a couple of images. What are these blocks over here? They are the somites. And somites are paraxial mesoderm. I'm writing PM, paraxial mesoderm. And you should know what they give rise to: scleroderm, dermatomyotome. Which skeleton? Axial skeleton. Which myotome? Lot of muscles. Okay, trunks and limbs. And dermatome, mainly of the dorsal body wall. Look over here. Bones in the hand. So let us go one by one. Okay, now we have talked about the derivatives. Bones in the hand over here. Appendicular skeleton comes from lateral plate mesoderm. Is it somite? No. The skeletal muscle in the arm. Yes, a myotome goes. Yes, this looks like B, looks like the answer. Let us see other options. Here, ectoderm. Which ectoderm? Surface ectoderm. The lining of intestines, endoderm. So you can now know all the four options. Okay, answer becomes option number B. First of all, understand what are the X referring to. They are referring to the somites, paraxial mesoderm, and then apply your theoretical knowledge and rule out the other options as well. And next question: which structure is derived from the same embryonic primordium as the kidney? Okay, so kidneys are derived from which structure? Intermediate mesoderm, IMM. IMM gives rise to what other structures? Some of the genitourinary structures. Let us see, gonads. Yes, definitely. Testes and ovaries, they come from the intermediate mesoderm only. Epidermis, ectoderm. Pineal gland, again, neuroectoderm. Liver is endoderm. A bit of mesoderm is also over here, but you'll see once you'll do the abdomen part. But it is definitely not intermediate mesoderm. Answer is our option number A, that is gonad. Which structure is derived from the same embryonic primordia as the spinal? Well, it is posterior root ganglia. What is posterior root ganglia? Simply dorsal root ganglia. If you once you go to the head and neck part, no, so CNS part, you have spinal nerves. In spinal nerves, you have the sensory nerves, and they have their ganglia known as this. Now, where are the ganglia basically coming from? NCC, remember, neural crest cell. And therefore, you should know out of these four options, the NCC also gives rise to what? Option number A, I guess you all will agree, adrenal medulla. Kidney, intermediate mesoderm. Liver, again, endoderm, mainly bit of mesoderm. Lungs, again, mainly endoderm. So neural crest cells give rise to ganglia, adrenal medulla. Other structures were also there. If you just revise, odontoblast was there, Schwann cell was there, melanocyte was there, conotruncal septum of the heart was there. All the ganglia, including the parasympathetic ganglia, it was there. Okay. Okay. One more question. Then we'll come to our next topic, that is the heart development. 20-year-old woman is surprised to discover that she is pregnant. Following a review of her menstrual history and sexual activity, her physician determines that she is in the 4th week of the pregnancy. Sometimes pregnancy misses, periods are up and down, so female might miss them. Which of the following best describes the condition of the embryo at this time? So basically, out of the four options, what best determines the 4th week of pregnancy is what the question is actually asking you guys. Let us see. Option A, gastrulation is complete, resulting in 2 germ layers. Think right or wrong. You can even pause and think for a couple of seconds. Gastrulation complete. Yes, sir, gastrulation was done in 3rd week. It's complete in 2 germ layers. But so it was 3. So this is the embryo is entering a period of relative resistance to teratogenic substances. See, teratogens, they actually have a huge impact in the first 3 months, not 3 weeks, for the first trimester. So it is not like that in the 4th week the embryo has become resistant. No, it has not become resistant till now. So yeah, this statement is also not correct at all. Neurulation is nearly complete. Now the word nearly will also help you. Neurulation starts when? On week 3. Okay, and when do the pores close? Pores are around day 25 to day 28 is what we learned yesterday, that yeah, anterior posterior pores, they close around this time. So is it the 4th week? Yes, it is the 4th week, and looks like a good answer. But they are also use the term nearly complete. So yes, that looks like a good option. Somites have not yet formed. No, no, no. Somites, that is mesoderm. It has begun to form in week 3. That is why we said that in week 3. And let me add over here a bit of a small bit of knowledge over here for you guys, that the somite stage of the embryo, because sometimes you can even determine the age of the embryo in days, age of the embryo in days, by counting the number of somites. Somites start from around day 20th, that is the 3rd week itself, and they continue being formed by till 10 or 11 more days around day 30. Each day, 3 to 4 pair of somites are formed. Each day, 3 to 4 pair of somites are formed. So total around 35 to 38 pair of somites are formed in the span of 10 to 11 days. Understand this. So if you see a picture which is showing you, say, say what, say 15 pair of somites. 15 pair of somites, you might, okay, 3 to 4 days have passed at least. So the embryo might be around 23, 24 days. Yes or no? Each day, 3 to 4 pair of somites are formed each day, per day, each day. And total number comes out to be around this much. Understand this. Somites is begin to form on day 20 and they keep on forming till day 30. Forming means number begins to increase. Then they have the whole process of dividing into sclerotomyto and then they divide and all. That's a different story. But remember the somite stage. So answer for this question is option number C. Okay. Fair enough. Let us see now our next part, that is the CVS development, and let us move towards the development of CVS over here. For that, I will try to show you a table, a simple diagram that is going to, help your life a lot. Right? Okay. What is this? Understand, for the development of the heart, let us first of all understand few stuff, and then we can come to the main topic over here. When we talk of the development of heart development, there are few things that we need to understand. Okay, I'll just touch on the important topics. Then the table itself is quite sufficient. Heart development is basically started from a couple of your endocardial heart tubes. There are two tubes. Okay, these two tubes, they begin to fuse from cranial to caudal end. So the final image comes out to be like this. This I'm telling you about the development of heart. So there are two endocardial heart tubes. Okay, they fuse from cranial to caudal in this direction, and then the picture comes like this. And then basically heart is coming from a tube. Now what happens? There are two things mainly. If I say not two, but yeah, three things that will happen over here. Understand this, what is happening. And remember, heart is one of the first organ to develop in an embryo. Why? Because once the placenta will begin, no, the blood will come to the fetal capillary. Then which system will not transmit that whole nutrition to the entire body of the developing embryo? Think common sense. Common sense. Embryo is inside the mother's womb. Placenta has begun to develop. Primary, villi, secondary, tertiary. Then there is hemochorionic placenta we discussed yesterday. If not, then please go and watch that video. Now, maternal blood is very close to the fetal capillary or the villus capillary. Now, nutrition is coming to the fetus and the waste products are going from the fetus to the mother. Good. Oxygen also coming through that system only. Now, the things have come into the fetal body, but who will circulate it? Therefore, heart is one of the first organs to develop. Now, there's a tube over here, as we can see. Now, what happens to this tube? 2-3 things that will happen. One is that there is going to be folding of the tube. Folding, yes, folding. Then there's going to be few dilatations that you will see in the tube. Then finally, there's going to be septation of the tube. Fine, sir, but so what do they actually mean? Folding means if you look at an adult heart, let me show you an adult heart also. Adult heart, if you look at an anterior view, it appears like this. Anteriorly, you have this chamber as a right atrium, this chamber as a right ventricle, and this chamber as a left ventricle anteriorly. Okay, but if you look at the heart from the posterior aspect, so this is anterior, let me below make a sort of say posterior aspect. If you look at the heart from the posterior aspect, this entire over here is left atrium. This is left ventricle, and this will be the right atrium, the right border. If you're looking at a heart posteriorly. Okay, so what happens is folding. Folding means that the heart will begin to fold somewhat like this, and there's going to be folding. Okay, why folding? Because atria ventricle have to be aligned to each other. They can't go like this, like the blood is coming from above and going from below. It's not like this. Getting a point? So there's folding, and then there's why dilatation? Because somewhere you need the development of atria. Okay, it needs to dilate, blood has to collect in atria. And then somewhere you need the development of ventricles also. And then somewhere you need the blood vessels to come out of them. Like from ventricles, we have the aorta coming out. You need to have separate dilatations, yes or no? And then what about septation? Because obviously you have a right atria, left atria. You have right ventricle, left. How will they divide? And about same, not just the chambers, but even their outflow channels like pulmonary trunk, aorta, pulmonary veins, vena cava. Where will they? They will have to enter into one chamber. No, so you need some septation also with that divides. So these are three major things that you need to understand first. Folding, dilatation, and septation. If this point, basic point is clear, then you can look at this image and try to understand this over here. This over here, let me first outline a bit. This is that tube which we are actually talking of. This is that tube that we are actually talking of. Okay, like this, and similarly on this side also. Right? This was that tube. So you can see some dilatations over here. Folding is not shown right now, else you will get confused. Right? And septation also is not shown, but you can understand. In this dilatation of the heart tube over here, the above part is known as the cranial or the arterial. So this end is the arterial end. This is arterial, also known as the cranial end of the developing heart tube. And the lower end is known as your venous end or your caudal end. Now understand the adult anatomy of the heart or how the blood circulates. If I just revise it for you guys, though it is very basic, some of you might think, sir, why are you telling this? We all know, but still understand. All the blood from the body will come from SVC and IVC. Yes or no? Where does it come to? It comes to right atrium. Agreed? Adult. From right atrium, that blood will go to right ventricle. Yes or no? Yes, sir. From right ventricle, the blood goes to lungs via pulmonary trunk. Okay, lungs via pulmonary trunk. Clear? Okay, from the lungs, the blood, now the oxygenated blood. So this is what this is deoxygenated. And now from the lungs, this will be oxygenated blood. So it comes via pulmonary veins, comes where? It comes into the left atrium. Very good. From left atrium, that blood will go to left ventricle. Clear? And from left ventricle, we have the aorta that goes again to the entire body. So that goes to the entire body over here in adult. And from again, after that whole tissue metabolism, it enters back through the SVCs or the IVCs. I hope the point is clear. Just remember this part is that is oxygenated. So if you look at the adult anatomy, okay, you can see that this venous end, the venous end is where the blood is actually coming. If I may try to show it with say some blue color, I guess you will correlate it more. Yes. So this venous end over here is this lower end. So the blood is actually entering from this side. And you can see that is known as what? Sinus venosus. What is the name of it? The first bulging below is sinus venosus. This is a very complicated. It is not a complicated name. It is a very easy name. Venosus is venous. That is your venous blood. And sinus means dilated veins. Sinus itself means a structure that is dilated. So sinus venosus means a dilated vein. Its literal meaning is dilated vein. So you can see the venous blood, the blue color blood is entering. And where does it enter to? Atrium. You can see all this venous blood is entering where? Atrium. Yes or no? And even the pulmonary veins are entering to atrium. But now the change is the lungs are present in adult, not the embryo. They are present, but they are not working that way. They are still in the process of development. So the venous blood is entering into atrium. Now the atrium blood goes where? Both sides. Goes into ventricle. Therefore, the next adjacent to atrium, the next dilatation is ventricle. Okay. From ventricle, it will go where? It will go into the, because there are two ventricles. You have a right ventricle, you have a left ventricle. They'll go where? Into pulmonary trunk and aorta. Here you can see. So the picture is clear. That is the arterial end. So the blood will eject out from here and it will come in from this side. Now, let us see some of the questions, because if you understood this image, then it is going to be very easier for you guys. There are some things which I'm seeing are not clearly written, but let me try to help you over here. So what are they known as? One is the sinus venosus, clear? I'll tell you what they derived. Second is atrial, then is ventricle. This ventricle fold over here, it gives rise to only the LV, left ventricle. Then you have this whole part that is known as this whole the dilatation present on the arterial end, that is known as bulbus cordis. What is that known as? It looks like a bulb. Bulbus cordis. It's proximal 1/3. It's proximal 1/3. It forms actually the right ventricle. It was slight mistake, or let me correct it. It is right because LV is already formed over here, so it forms the right ventricle. Then its middle part. Proximal part is forming the right ventricle. Middle part, it forms the smooth part of the right ventricle. Okay, not trabeculated, but it is the smooth part. And finally, the distal part of the bulbus cordis is known as truncus arteriosus. So what is his name? Truncus arteriosus, simply a trunk of artery. Arteries are coming out. So they are forming both the arteries. Pulmonary trunk is pulmonary artery only. It is pulmonary artery, right? So this distal part forms the aorta and pulmonary artery. The bulbous cordis has three parts: a proximal, middle, and a distal part. Proximal part forms right ventricle. Middle part forms the outflow part of both right ventricle, left ventricle. Outflow means, see, when the right ventricle, left ventricle, they will eject out the blood. Then once the blood is ejected out, that small part just before the aorta or a pulmonary trunk is smooth. Why? Just understand there are two arteries over here, just for understanding. Okay, there are two arteries over here. One artery, the proximal part is smooth, and in one artery the proximal part is a bit rough or trabeculated. Trabeculated means there's muscles over here, muscle ridges are, you can see over here. Now if I ask you that if the blood is flowing in both of the arteries, okay, in which artery, the A or B, the blood will flow in a streamline or in a very smooth manner. You also obviously said this above an A1. Therefore, the outflow of both the RV and LV, they need to be smooth. That is this middle part. It forms the doesn't form the primitive right ventricle, but forms the outflow part of both RV and LV. That is the point. Because if it is smooth, no, blood will go in streamline. If it is very rough, then the blood will come and it will strike the walls here and there, and the blood will be on this haphazard. It will not be streamlined. It will be haphazard flow of blood, and that will obviously increase the blood pressure, damage the wall of the artery, and there are a lot of consequences that you will learn later on. So this is all the dilatation. Now folding and septation will occur. Where will the septation occur? Septation has to divide what? Understand. I hope this point is clear. If not, then take a screenshot. There's one more image of it. Don't worry. We have one more image of it. Just for a more labeled part, this was there, but you can understand this also. I'll just go through that. But now folding is there. And apart from folding, the third point was the septation. Now you tell me which part needs septation. Sir, this part, atrium, because we have right and left atrium. Yes. So this atrium needs septation. Let me just highlight with a light green color the area that needs septation. So somewhat over here we need septation. Yes or no? Between the ventricles also we need septation. Then this truncus arteriosus that was forming the aorta pulmonary trunk, they can't be same. So here also we need some septation. Yes or no? Therefore, the third point which I said was the septation. Okay, now coming to your questions. All this stuff over here is actually quite important. Let me highlight the few more important ones. Sinus venosus has a right horn and a left horn. The right and left horn, they are two different horns, and they actually enter into the right atrium. Okay. Now, if I ask you SVC, IVC, that was entering into which atrium, right or left? You'll say right atrium. Yes. Therefore, there is a right horn of sinus venosus. It gets actually absorbed into the right atrium. And the left horn sort of retrogresses, means it slowly disappears. So right horn of sinus venosus, remember, it is a part of right atrium. It is a part of right atrium. Remember, that is very, very important. It actually fuses with the right side of atrium. Understand this part. Left horn sort of disappears, but very good MCQ can come that it forms a part of coronary sinus. Coronary sinus is what? You must have learned in the thorax part. It is the vein of heart. So remember this, right? Now you can see even the body of sinus venosus is being absorbed into the right atrium. Now from the atrium, the blood goes into ventricle through the AV canal, where you have the mitral valve and the tricuspid valve. Between RARV, we have the mitral. Between LALV, we have the between RARV, we have the tricuspid. LALV, we have the mitral valve. So it is AV canal. Then in the ventricles, you will have some septation over here, known as interventricular septum. Here we call it as interatrial septum. Okay, and then from again, as the outflow of the RV and LV come out, this truncus arteries also you need a septum. This septum over here is a spiral septum. We'll see it. This is very special septum, spiral septum. It actually spirals on its own by 180 degrees. Spirals on its own by 180 degrees. Now, I hope this picture is clear, right? Let us see this image also. So, right horn of sinus venosus forms a part of right atrium. Primitive atrium forms your LA and RA. And AV canal, if a primitive ventricle forms LV, and you can see the bulbous cordis, it has a proximal part. So this part becomes RV, this part becomes LV. Then you have the distal part, it forms the outflow part. And the more distal this forms, the truncus arteriosus, forming the both the ascending aorta and the pulmonary trunk. Okay, simple. Here's a bit more details over here. Okay, this point is clear. There is development of the heart. Now let me move back to few. Okay, just a second. Yeah. This is what is shown as the folding. So you have seen the dilatations over here. This is the arterial end of the heart tube, that is the venous end, and here you are seeing the folding being happening over here. This is why you see the ventricle in front. As I showed you in the adult heart, no, this maximum occupied by RV, a small right border only by RA. So maximum of the anterior part you can see is being formed by the ventricles over here, and atrium normally go on the posterior aspect. Okay, let me show you one more thing. Yeah, this is the formation of interatrial septum, IS, interatrial septum. It's a bit complicated. Why? It's a bit complicated. The reason being that in developing embryo, there are no lungs. And developing embryo, what happens? Whatever blood comes to the right atrium, it immediately goes to the left atrium. So the what we say, the fetal circulation is entirely different. So I would advise you to kindly go through this topic as well, the fetal circulation. Take your time. If you have any doubt, let me know. I will conduct a session on that too. I'll include this topic also in a session, fetal circulation. In nutshell, you should know that in fetus, when the oxygenated blood comes into the right atrium, it rapidly enters into the left atrium. Because there's no point going from RA to RV, not the oxygenated blood. Oxygenated blood, if it comes to RV, from RV, where will it go? The lungs are not yet developed. So it has to somehow bypass, and then again it has to come to the aorta and all. So basically, the blood from RA goes to RV. Sorry, blood from RA goes to LA. From LA, the blood will come to the LV. And from LV, the good blood, that is the oxygenated blood, goes to aorta. Then, sir, what about the deoxygenated blood? Let me tell you that also. The deoxygenated blood is the SVC and IVC, right? These, mainly the SVC, a bit of IVC, these actually directly enter the right ventricle. And then from their right ventricle, they go to pulmonary trunk, but the lungs have not yet developed. So what happens is, from pulmonary trunk, there's a structure, there's an artery known as ductus arteriosus. From there, it will enter the aorta. So aorta gets a mixture of blood. This aorta will get the oxygenated blood also a deoxygenated blood, so it gets a mixture of blood. Then, sir, what happens to it? Finally, via umbilical artery, it goes to placenta. And so from placenta, you have the umbilical vein. Now here the vein is carrying the oxygenated blood. So I would like to change my color to the red over here. So from the placenta, umbilical vein is the one that is giving rise to this oxygenated blood. I told you the fetal circulation in an elaborated manner or in a concise manner over here. This is the fetal circulation. So now this intraatrial septum, what actually happens is, how does it develop is, you have a septum. Let me also take this empty slide somewhere over here. Just a second. One second. Yes, let me use this only. Just to let you know about the interatrial septum in a couple of minutes. Suppose this is the entire common atria, and below you have the ventricles. In between this, you have the atrioventricular cushion. They are known as AV cushions, where you have the AV canal, also known as your endocardial cushions, because all is endocardial only, Okay, above is the common, this is the common atria over here. This is common atria. Now, understand how the interatrial septum develops. So initially what happens is, there is one septum that goes down, that is known as septum primum. SP, I'm writing septum primum. When the septum primum goes down, there's a space in between, that is the space between the lower border of septum primum and the AV cushion. This is known as FP. What is FP? Foramen primum. Okay, now septum primum comes down, and fuses with the AV cushion. But if this happens, then all the oxygenated blood has nowhere to go. It will all come into the RV, and from RV it will confuse into the lungs. Is not developed. A small ductus arteriosus can't divert the entire blood into the aorta. So now what happens is, as soon as the septum primum goes down and fuses with the AV cushion, simultaneously at the same time, the small perforations will develop over here. And a part of this septum primum will disappear, right? And this becomes in the foramen known as foramen secundum. Foramen means a hole. So initially there was a foramen primum which actually got closed. But as the FP got closed, the FS developed. Now the blood can easily, now imagine the oxygenated blood can easily come to the right atrium. This is the right atrium, that is the left atrium, and then it can go over here. But what after birth? If you leave a hole like this, what after birth? The blood will confuse now where to go, because whenever this pressure increases in RA, it will go from RA to LA. When there is a high pressure in LA, the blood will go from LA to RA. So there's no point. It is known as interatrial or atrial septal defect. That disease is known as ASD, atrial septal defect. It is one of the congenital heart defects, one of the common ones. Now see what happens. We can't leave it like a hole like this. Therefore, nature has made one more septum. And that septum is a thicker septum, comes along onto the right side, and it covers the foramen secundum like a valve. This is septum secundum. You cover it like a valve. Then this actually, all of this that forms the foramen ovale, we call it as foramen ovale. That is your intraatrial septum. Read it again, you'll understand. I will just repeat what I've said. Initially, there is septum primum, which is coming down to be fused with AV cushion. It fuses. Before it fuses, there is that temporary foramen primum. So foramen primum gets obliterated. But before it fuses, it leaves, there's also some apoptosis going on. The cell death goes on, and a second foramen appears, that is foramen secundum. But you can't leave the foramen like this. It is not sustainable after birth. Therefore, you need a covering, that is septum secundum, that develops again on the right. After birth, what happens? This actually septum secundum actually fuses with this, and it becomes a common intraatrial septal wall. That is what happens. And if you see it from this image, yes, over here, now you can correlate, I guess, better if I use a highlighter over here. This is your septum secundum, understood, on the right side. This is your foramen ovale, that same thing going from blood from here to here. This is septum primum. This is the left septum primum, and this is the upper part with foramen secundum. So where is foramen primum? That is lost. And this in the center, that is endocardial cushion. These are the RVs and the LVs over here, the right ventricle and the left ventricle over here, right? And that becomes the right atrium and the left atrium over here. This is your interatrial septum development. Okay, remember this. Okay, let me show you. This is one more thing which I wanted to show you over here. What is this, sir? This is your, remember a truncus arteriosus? Yes, sir. It was the most cranial end. So you had the RV, LV being developed over here with the septum in between, and then you had a truncus arteriosus. That is a common truncus arteriosus, but you need a septum, and that septum actually goes like this in a 180-degree manner. As I said, it is a spiral septum. Okay, this can you see, and that is also known as aorticopulmonary septum. This is the same spiral septum. You can see it is how it is rotating now. It is normal. It is normal. If it does not rotate like this, then what happens is first of all, under normal conditions, RV opens, or its outflow is pulmonary trunk, and LV outflow is ascending aorta. You can say aorta. That is normal. This all is accomplished once there is a spiral septum. Fine. Now, if the septum is not a spiral, if it is coming straight down, then what happens? RV opens into aorta and LV opens into pulmonary trunk. This disease is known as congenital heart defect, known as transposition of great artery. There are many other things. There's also patent truncus arteriosus when there is no septum, known as patent truncus arteriosus. Patent means there is no septum. There's one more disease like this. Then there's also your phallus tetralogy. Phallus tetralogy is also there. So there are many diseases, but yeah, one more over there, transposition of great artery. These are some of the important things which you need to know from the heart development side. Let us do a couple of MCQs over here so that we can test our knowledge of how well we are going or not. Just a second. Let me use a highlighter over here. Yes. So question over here is, which embryonic structure normally fuse to close the foramen primum? Okay, let me make it like this, just coming down. This was your initial FP. So this septum primum has to fuse with endocardial cushion. So septum primum fuses with endocardial cushion. Answer is option number C. Am I correct? Or are you guys correct? more than me. Are you guys correct or not? These have to fuse to close the foramen primum. Okay. Which of the following congenital heart defects is the direct outcome of the malformation of the spiral partitioning of the conus cordis and truncus arteriosus? Right? Gave you 2-3 names like patent truncus arteriosus, Feld cetrology, and transposition of great vessels. Here you have option number B, transposition of great vessel. What happens over here? RV opens into the aorta, LV opens into the pulmonary trunk. Okay. Okay, one more. A 78-year-old comes to the physician because of shortness of breath, dizziness, and fainting spells. 78-year-old, understand? Physical examination shows a distended neck, veins, and peripheral edema. Peripheral edema means swelling. A popping sound is heard on auscultation of the heart. Echo was done that shows a large mass arising from the smooth part of the right atrium. Echo was. The region of the atrium, this region of the atrium derives from which of the following empties? So the whole, it was a clinical case, and in the end they asked you, in the echo, they are showing something coming out from the smooth part of the right atrium. Embryologically, it is part of which? Now you know that which part of what forms the smooth part of right atrium? It was the sinus venosus of, and if I ask you over here, which horn of sinus venosus, right or left? That I guess you can easily answer. Okay, so that is your sinus venosus is the answer over here, right? So guys, this are some of the questions and some of the embryology we dealt with. The so in a nutshell, if I just go through of what you guys need to do is, first of all, remember all the derivatives of all the 3 germ layers plus the neural crest cell. Secondly, this heart development is damn important, guys. Damn important. Why? Because you might not see its implication right now at that much bigger scale, but once you reach your 3rd, 4th year, pediatrics, you will see a lot of it. Medicine, you read a lot of congenital heart defects. It's very, very important. A lot of adult diseases are dependent on this. So go through the heart development in detail a bit and try to make some diagrams, flowcharts. They are must. So that's all on my side, guys, tonight. Bye-bye, take care, and do revise, and see you soon with our next topic. Our next topic will probably be the upper limb part. So we have divided the upper limb into, I guess, 3 sessions. We'll try to cover it up, right? That's all. Bye-bye. Good night. Take care. Thank you.